So it's my pleasure and honor to provide you some take-home messages for the general and also invasive and non-invasive cardiologist. What I think is worth to take home from this Congress regarding coronary artery disease. I divided it up into 4 points. First, new guidelines for coronary disease, diagnosis of that disease, therapy regarding drugs, and therapy regarding PCI and bypass surgery. So let's start with the new guidelines. As you know, 5 new guidelines more or less came out during this meeting, but we talk only about coronary disease, so of course let's focus on myocardial revascularization. It's fully published, 70 pages, it's okay, 22 task force members, plus additional 53 reviewers. I had actually the honor to be one of the reviewers to actively contribute to these guidelines. So it's a major work. What is new in the guidelines? New in class 1, listed here, as you can see, but I will, of course, for the sake of time, not read all of them. Let's just focus here on PCI. Drug-eluting stents for any. So bare metal stents are really out. Bare metal stents should not be used anymore. Another interesting aspect here is that patients with acute coronary syndrome without ST segment elevation, when they are stabilized, the decisions, PCI or bypass surgery, the decisions should be made like in a stable patient. So he is not unstable anymore, he is stabilized for the decision making. New recommendations, class 2A. Again, I will not read them all, just here emphasize that if you combine anticoagulation with antiplatelet drugs, NOACs are clearly preferred over vitamin K antagonists. Class 2B, new recommendations, again a whole list, I will not read it all, just regarding anticoagulation. If you use dabigatran for dual therapy, the 150 milligram dose is clearly preferred over the 110. So if you do dual therapy, do not reduce the dose just because you add antiplatelet drugs. There are 2 new don'ts. Class 3, don't do it. Don't routinely revascularize the whole patient if it's in cardiogenic shock within a heart attack. So do only the infarct-related artery, the patient will do better. The second don't is, as expected, completely bioresorbable stents or scaffolds you should not use anymore. Well, they did not differentiate between polylactate and magnesium. So you can still implant magnesium scaffolds, but the patient has to be in a clinical study enrolled. There are several upgrades, change of recommendation. Just here, I emphasize that for bifurcation lesions, there's a clear upgrade recommendation. Use only one stent, main vessel only, unless you are forced to do so. And OCT also has been upgraded for stent optimization. Downgrades, yes, there are downgrades. Some example is bivalirudin here. So the good old unfractioned heparin is still valid. Platelet function tests, they don't play a role anyway a lot, but they have been downgraded again. So what about diagnosing coronary disease? I picked up for you the Scott Hart trial. Well, you would say this is not new. The 5-year results, yes, but I think it's important to look at the 5-year results because we can learn a lot of this. This study was criticized a lot because the use of coronary CTA increased the number of cardiac catheterizations and it increased the number of revascularizations. As you can see here on the left side, in the first year there were more caths in the blue group, which is CTA, than in the standard group. But after 5 years, as you can see here, it levels off. So the netto effect is plus minus 0. And on the right side, you see coronary revascularization. There were more revascularization in the CTA group, and after 5 years, it levels off. So what does this mean for the patient? does the patient have a benefit? And the clear answer is yes. The curves separate very early. This is the primary endpoint, death or non-fatal MI. So the patients really are more and better selected with coronary CTA for a better prognosis. So the conclusion of this major trial was the coronary CT angiography guided reduces 5-year coronary heart disease. And on the bottom you see the question, should CT angiography be the non-invasive test of choice? Some people say yes, even the NICE guidelines have emphasized this, and that's important. But still, the coronary CT shows us only anatomy. Still, we do everyday ischemia testing, and the gold standard for ischemia testing is myocardial perfusion scintigraphy or SPECT. This was a nice poster picked up here comparing in the same patients SPECT on the left side and CTA on the right side. And what it showed nicely, indirectly, is if SPECT is normal, like the white bar, you still have a benefit of the CTA on the right side to reduce the MACE rate to select the right patients. But if scintigraphy is positive, like here, then actually CTA doesn't make any sense anymore, and you should go straight to the cath lab. Well, the standard test for provoking ischemia is exercise, but in our experience, about 20% of the patients cannot do physical exercise, so you need pharmacological stress test. The standard drug is adenosine, and this is, so to speak, Prodromo. I'll show you our own results here, which we presented in over 5,700 patients with regadenoson. Regadenoson is known to have less AV blocks than adenosine. Well, we had prospectively collected in these 5,720 patients. The side effects, they are minor. Patient has some shortness of breath, but this is only transient. The question is, do severe side effects occur? The answer is yes, but very, very rare. It's less than 1 per mil, but you may encounter a systole or third-degree AV block, even symptomatic drop in blood pressure, very rare. So it is still much better than adenosine, but be prepared to have the antidotes ready, like theophylline and atropine. Another ischemic test is FFR. It's very well established for this differentiating between to stent or not to stent. But where FFR is less well investigated is in multivessel disease, to differentiate between patients who go for PCI or for bypass surgery. And this was the goal of the future trial. They used FFR to make this decision. Here are the results, really shocking. I thought they mixed up the legends. No, FFR had a much higher death rate. FFR guided had a much higher death rate than angiographic guided. So how could that be? Of course, people went into details, and as you can see here, in the FFR group, the syntax score was much higher than in the angiographic guided group, and the percentage of three-vessel disease also was much higher. So one explanation might be that probably FFR guided decision in multi-vessel disease puts more patients to PCI who really would have done better in getting up surgery. So even with syntax score, especially over 32. So of course we have to wait for the final publication to see the details. What about drug therapy in coronary disease? Long awaited Commander HF study in patients with sinus rhythm and heart failure and low dose rivaroxaban. Why do we do such a study? Well, the background was clear. Patients who had a positive history of heart failure in 2 studies, ATLAS ACS and COMPASS, actually did better. So Commander HF was the proof of principle. Is this the right concept? And as you know, actually there was absolutely no difference between both groups. One explanation was that if you compare COMPASS patients with Commander patients, the Commander patients were much sicker than in the COMPASS trial. So I think what we learn also from this is that patients with severe heart failure, atherothrombotic events, are not really the limitation. It is the underlying disease. It is the heart failure. We already knew many years ago that statins are also not very helpful in these patients, again showing that atherothrombotic events are not in the first line of these patients. But interesting, there was one subgroup analysis with stroke, and there's a huge differentiation between placebo and low-dose rivaroxaban preventing stroke. Although this is low dose, 2 times 2.5 milligrams per day. Well, this was not statistically significant. Anyway, it's only one component of the major endpoint. But the question is this enough to change your policy? And this was asked in the audience. Would you change your policy, yes or no? And as you can see, 91% of the people in the audience said, no, this is a negative trial, I will not follow this. But I was surprised, 9% of the audience would still go with low-dose rivaroxaban in patients with sinus rhythm and heart failure. Well, we are physicians, we are free to decide. The other major drug study for coronary disease was the Global Leaders trial. What was the goal? The goal was to get rid of the old aspirin. So this is why they did dual therapy only for 4 weeks with ticagrelor, and then for 2 years monotherapy with ticagrelor. The control groups are listed here: ACS, dual therapy with ticagrelor, and then aspirin monotherapy in stable patients with clopidogrel. Here are the results, a little bit disappointing. The primary endpoint was not reached. There was a little trend, as you can see here, all-cause mortality or new Q-wave MR, but of course far from being significant. So what was the reason? Why is ticagrelor not so good as aspirin? Is aspirin still the best? This is a major limitation of the trial, but this is the real world, that the adherence to the drug was much less with ticagrelor than with aspirin. So after 2 years, about over 20% of the patients in the ticagrelor group dismissed the drug. So they actually had no antiplatelet drug. They had no aspirin, no ticagrelor, whereas a much lower percentage was discontinuing aspirin. So we have to think more about the side effects and how we can avoid it. So again, there was a question in the audience: is this sufficient to change your practice? And the majority said, no, I will not implement this in my daily practice. Last but not least, what's new for PCI and bypass surgery? Well, here's a table of the guidelines. Which drug-eluting stents are recommended? Only 12 drug-eluting stents. So use only one of these 12, because these are the only drug-eluting stents where a randomized trial has been conducted with a primary clinical endpoint. What about the surgeons? The surgeons have several recommendations. So let's focus on the radial artery. So the surgeons were recommended use radial artery over saphenous veins whenever you can, in high-grade stenosis, of course, yes? But there's a D. As you can see, there's a D. And it says the radial artery should not be used if previously catheterized. So if a radial artery has seen a cardiologist, the surgeons are not supposed to use it. On the other hand, and this is contradictory, the radial access is a 1A indication. It should be used as a standard approach. So there's some conflict which is difficult to solve. The last study regarding surgery, I'll show you here, is the ART trial. It has been long time awaited. Why? Because the primary endpoint is at 10 years. Only surgeons can do that. I don't know a cardiologist who does a primary endpoint after 10 years. So they compared bilateral mammary artery with a single mammary artery, and absolutely no difference. Very disappointing results. Well, if you do a combined endpoint, looks a little bit better, but still not significant. So what was the reason for this? There's a huge crossover, and well, you cannot avoid this. But, and this is my major last take-home message for you, it seems to be related to the operator experience. So those who do more than 50 surgeries a year, actually there was a significant reduction in mortality even with the composite. But those who have a low volume, they have a major problem. And this is not only true for the surgeons, and this is my last slide, but only for coronary interventions. So this is a table I would ask you to look very carefully of these new guidelines with minimum operator volume or institutional volume. So it's really important you know the volume of the operators, of the surgeons, of the interventional cardiologists, where you refer your patients. Thank you.
Thank you very much, Sigmund. That was a very nice wrap-up of everything. Thank you very much, everybody, for being here.
Goodbye, and have a safe comeback home. See you in Paris next year.